revision, I guess. So, all right. Once again, thank you everyone for joining us. I know there's a panel meeting going on with the Rainbow team, so we'll start off with their cases. We have 8 new cases, and we again appreciate your comments and suggestions on the chat box. Let's keep it active, and hopefully we'll get to the bottom of some of these cases. We'll start off with the first case if Devangna is there. Devangna, go ahead.
Yes, sir. She is a 4.5 years old female child who had come to us at 6 months of age with motor developmental delay. She was born of non-consanguineous parents, forced by birth order with no perinatal complication. Family history of delayed milestone in mother and maternal uncle was present. On examination, other than hypotonia, the child had normal head size, mild central hypotonia with gastrocnemius spasticity was there. Investigation wise, CPK and TFT was done, which was normal. Then we went ahead and did the MRI, followed by genetic testing.
Okay. Before we move to the MRI images, Raghu, can you just make Dr. Sarah as panelist? All right. So yeah, these are the most recent MRI images we have. And on top, we have the T2 axials. And you can appreciate that the supratentorial brain appears normal. There is no structure abnormality, no white matter changes, no deep gray nuclei abnormalities. Coming down to the posterior fossa, where the major findings are present, the sagittal image demonstrates a severely hypoplastic brainstem, especially the pons. The pons is slightly hyperintense, especially in the pontine belly. The vermis is also severely hypoplastic and also demonstrates slight hyperintensities on the T2 sequences. You can argue probably the corpus callosum is mildly thin, but the main changes, as just again seen on the coronal images, the cerebellar hemispheres also are atrophic and hypoplastic, and there are some areas of cystic foci along the peripheral regions you can appreciate over there. And the cerebellar hemispheres in general are hyperintense on the T2 sequences. More closer zoomed in images, again, you can appreciate the cystic foci also in the vermis over there. And then you had these almost like transverse and horizontal lines crossing the brainstem, predominantly in the olivopontine nuclei, and giving almost an appearance of hot cross bun appearance, not specific, but yeah, you can appreciate the pontocerebellar fibers and median raphe nuclei demonstrate these hyperintense changes. They visualize the vermis and the cerebellar hemispheres are hyperintense again. And you can appreciate that there is the absence or lack of because the cerebellum is so small, you can appreciate the CSF contents in the posterior fossa. The hyperintense changes are again better appreciated on the flare sequences. Similar changes with what we have seen on the T280 sequences. The diffusion-weighted scans did not demonstrate any acute abnormalities or restricted diffusion. The SWI sequences, at least of the posterior fossa, we could not appreciate any areas of abnormal blooming to suggest a possible hemosiderin deposit or calcification over there. The slice thickness for this was around 2 mm, so these are the limit for which we can see if there was any hemosiderin deposits along the cerebellar hemisphere or the brainstem. But at least on these images, we could not appreciate any abnormal foci. The first question to be evaluated was, could this be a genetic or an acquired cause? The pontocerebellar hypoplasia at least can present with acquired insult, especially in the antenatal perinatal period. From the most susceptible age is around 28 weeks to term. Some imaging clues which can be seen, maybe not seen in our case, they can be asymmetry. They can be hemosiderin deposits as demarcated over here on a T2 hypo intensities. And other associated findings of cysts, gliosis can also be seen. Then coming to possible genetic causes, these were at least the imaging correlates, and Dr. Bolthauser has helped us with a few of these cases. And you can see that the hot cross bun sign or the olivopontocerebellar degeneration is common in the spinocerebellar ataxia types, the multisystem atrophy type, but they are more commonly in the adult age group. There are some PCH variants which can also demonstrate similar imaging appearance. This is the case of an ITPR1 related spinocerebellar ataxia, and you can see that the severe pontocerebellar hypoplasia with hyperintense cerebellar cortex is almost similar to our case. And again, another new form of pontocerebellar hypoplasia, the INPP4A can have these similar imaging appearance. CDG1 previously described to have these hyperintense changes with pontocerebral hyperplasia, but at least clinically, I don't think the child resembles what was one expected of a CDG1 type disorder. Cerebellar cysts were seen, and this is again from Dr. Baldazo's paper. Few of the pontocerebral hyperplasias with cerebellar cysts can be 1, 2, and 6. Muscular dystrophies are common, but other imaging findings are not attributed to the congenital muscular dystrophies in our case. And then there was a whole exome sequencing done, I think, at the Magna.
Yes, the whole exome sequencing was done. And the whole exome sequencing was suggestive of PHIP mutations.
Okay. So at least in literature, I found, yeah, go ahead, sorry.
Yeah, which was an autosomal dominant heterozygous variant, but it was a variant of unknown significance.
Okay. So there's very limited literature on imaging, at least of this gene, and I found only 2 or 3 cases, and what they've described as the brain findings are unremarkable. So I think we can be confident that the gene is not a positive gene, but the question arises, first, is it an acquired insult? Is it a genetic insult? And what are the genes to be evaluated? I'll open the case for the panelists now to comment upon.
I think the imaging findings are not absolutely specific. The lack of hemosiderin is not an absolute argument against acquired condition. On balance, I'm not really sure. This could be genetic, could be acquired still. And also the increased signal intensity on the cerebellar cortex I have seen in cerebellar degeneration following extreme prematurity. So this is also not really an argument. Okay.
Dr. Lokesh or Dr. Sara, any comments on the presentation clinical aspects?
The question here was whether to further how to investigate for the future pregnancies, whether we can safely say it is acquired. So if we are not able to give, because it's mostly going to be based on radiological differential, and clinically the child has had very minimal motor progress at this point in time. And definitely PHIP is not a phenotype. I think Dr. Sara has collected few cases as well. Dr. Sara, you're there?
So yes, sir. Good evening, sir. Good evening, Dr. Nihaal. So this particular gene PHIP, what we had got on the whole exome sequencing was not a match to the phenotype of the child. And since we were thinking of PCH spectrum, which is why we went for the genotype first, and even just to be on the safer side to safely rule it out, we even went ahead with parental segregation, and it was segregating in one of the asymptomatic parent. And also the phenotype was not a match. And upon doing a literature search, the other genes also which could be like PCH presenting, like the CDG1, the CASK, the DKC1, all of them were rechecked and reanalyzed. And also the family was called, and we again we had asked for ophthalmology evaluation for the child. I think that is awaited in view of certain other differentials like the coenzyme Q deficiency, which can also mimic the PCH spectrum. And so we still do not have an answer for this child. There are around 13 PCH conditions with several genes. It could probably be that the exome was not able to pick up the mutation in these genes, or this is a newer gene which has not yet been described.
So clinically, I mean, it's more towards genetic than acquired, Dr. Sara or Dr. Lokesh?
So this baby was born at term, was appropriate for gestational age, cried immediately after birth, no postnatal sequelae. The only positive history was mother had hypertension. I'm not sure if that is related to PCH. I could not find any literature on the same. And so we are still thinking in terms of genetic.
Yeah, but a perinatal insult can still cause it. Is that, I think that's what Dr. Baltazar was trying to emphasize. So if there are any strong
in a term gestation?
No, in the perinatal period, which has happened antenatally, the injury which has happened antenatally. maybe in the last trimester, at that time it can cause, I think, similar imaging changes. Is that right, Eugene?
I assume there was no prenatal ultrasound during pregnancy. I remember a patient where an experienced ultrasonographer found a normal cerebellar anatomy in the week 22 or so, and after birth, an MR was done, and this resulted in almost cerebellar agenesis, also proving that this can occur as an acquired condition.
Would the cyst be of any imaging clue helpful? Again, are these clastic areas or just? I'm not able to make out. Yeah.
I don't think we have any specific clue.
Yeah.
In my limited experience. I mean, cysts can be dysplastic, can be also seen in the context of PCH2, but the overall pattern does not fit at all to PCH2.
Yeah. Dr. Sarah, what do we do next? I mean, are we going to further? I mean, other than the
we were thinking
examination?
we were thinking of CDG as a differential. So we thought on if the child had other features manifesting, like any liver abnormalities or coagulation abnormalities, or any other features which could be matching CDG, we would go ahead with the transfer and isoelectric focusing. So probably surveillance right now and monitor the child. And do a reanalysis as per the ACMG recommendations for negative reports. Maybe again relook for the genes each year. Reclassification and reanalysis.
I think Dr. Lokesh is asking a pertinent question. What do we inform the parents now if they want to have the counseling part of it? So just a question from my side. Do we ask the parents, what do we advise the parents now? Do we ask them to wait for the second pregnancy or?
Dr. Nihaal, so usually when we have negative reports, we tell them clearly that we do not have an answer, because in NGS, this is a very common challenge wherein we do not have a 100% diagnostic yield. So we tell them that we need to wait and surveillance the child depending upon if we are thinking, is it fitting in acquired or genetic? So depending upon joint consensus, then we decide if we put the child on surveillance, decide what parameters to look for, and also do that would be a phenotypic point of view. And genetic point of view, we will reanalyze the whole exome data every year for newer variants or newer genes to be found by literature review, as well as the lab's inputs on newer variants or reclassification of previously benign variants into pathogenic. So this is our normal routine strategy for negative reports. So it is definitely not a very clear answer, but this is what we do at this point of time.
Okay.
Dr. Nihaal, quick this one. The first and the recent scan, is there any progress? Or they are the same?
I have only one scan.
No, the family has had, I think, 2 scans. They got a recent scan. There is a previous scan. If you can look at if there is a progression, that might help us to say it's a genetic disease more or than the.
I mean, at least I think this is a recent scan. So whatever would have been there, it would have been. I mean, it cannot get smaller than this. Or I got it. So maybe if you have a look at the earlier scan and it is,
sure. Okay. Thank you.
That. Okay, got it.
Thank you.
Okay, next case, Devangna.
This is a 4.5 years old female child. She came to us for the first time with developmental delay. But this child has a significant history. This was a term child born of LSCS. But baby cried immediately after birth, but birth weight was 1.9 kgs at term. And developed apnea immediately after birth, for which the child was admitted to NICU. Total of 15 days of NICU stay, for which the child was on mechanical ventilator for 5 to 7 days. But there was no history of neonatal seizures or neonatal at that time. Now comes to us with developmental delay, microcephaly, spasticity, and dystonia. By the time the child had come to us, the child had already got the genetic testing done outside, and also and we did the MRI here, so MRI followed by genetic testing.
So course is progressive, static.
This child had not attained any developmental milestones like gross motor wise. At 4.5 years of age, the child has still partial neck control. Fine motor wise, she is dystonic with no approaching of object. Social smile is there, only babbling on language milestone. She has contractures all 4 limbs, spasticity, and bedridden, so with severe paraspinal weakness and hypertonia, with spasticity of all 4 limbs.
Okay, got it. We have the MRI, I think, done most recently, I think it was a couple of weeks back. And you can appreciate confluent areas of gliotic changes, hyperintensities in the bilateral periventricular deep, extending up to subcortical white matter. Some areas of cortical thinning in the frontal lobes over there. Coming down, the ventricles demonstrate a slightly dilated appearance with some scalloping over there along the external aspects. Coming down to the deep brain nuclei, you can appreciate that the thalami are reduced in volume and they demonstrate these hyperintense changes. Again, possible thalamic degeneration going on. The posterior periventricular white matter again has peritrigonal white matter has these areas of I think likely gliotic changes because there's reduction of corresponding white matter changes. Posterior fossa structures, the brainstem and the cerebellum appear normal in terms of volume and signal. No acute changes in terms of diffusion weighted abnormalities, and I could not appreciate any calcification or hemostatin deposits, especially in the affected white matter or along the ependymal margins. On the sagittal, you can appreciate that the corpus callosum is diffusely thinned out. And again, in the coronal sequences, we have these areas of periventricular gliotic changes, reduced volume, some areas of cortical thinning along the frontal and parietal lobes. The posterior fossa structures, in comparison to the supratentorial white matter brain, is relatively normal. No atrophy, no abnormal signal changes. In terms of the imaging pattern, or thinking of a likely acquired cause, given that possibly the neonatal period, the child had history of apnea, ventilation, hypoxic ischemic injury would be at least the primary imaging differential. Any infection also in the primarily affecting the white matter in the chronic stage can have a similar gliotic extensive gliosis and degeneration. So we're not sure if we have a neonatal scan or an ultrasound was done at that time. So at least on the imaging wise, we're thinking of, pointing towards more of an acquired insult, but I think the genetics was done, and Devangna, you can, yeah.
Yes, sir. This child had ABCC9 gene mutation, which is a homozygous autosomal recessive condition, and it came out to be likely pathogenic. It is an intellectual disability with myopathy pattern gene.
Okay. So does child have myopathy syndrome?
No, sir.
Okay. So at least when we got the gene, the literature, I found that there was only one paper demonstrating the MRI changes. And in comparison to our scan, there are extensive white matter abnormalities, but there's no reduction or gliosis over there. You can appreciate that the cortex is normal in thickness. The white matter also, you can see the volume is normal. There are only extensive white matter abnormalities. This was the only image we had in literature with this gene. Clinically, I think Dr. Sara or Dr. Lokesh Devangna can outline the clinical features of ABCC and ABCC9 mutations. I think facial dysmorphism and some form of cardiomyopathy is usually seen.
And may I jump in? As far as I see briefly, these patients do not have microcephaly, and they are not spastic dystonic as your patient, but they are hypotonic. So I have great doubts whether this is compatible with a clinical context. And in view of the severe neonatal complication you had with intubation and ventilation for several days, this is very likely an acquired condition. It's PVL in the broad sense. This can also happen in term neonate.
Yeah.
And it explains the microcephaly, the spasticity, and you also had abnormal EEG at the beginning. This is far more likely an acquired condition.
Any comments on the gene, Dr. Sarah, Dr. Lokesh? Or I don't think there's a clinical match to.
Do we have pictures of the face, the Bangna?
Actually,
definitely the child was only dystonic. Absolutely no features of myopathy on examination. The likely event in the gene testing. So we wanted to just clarify before the committee counseling the family. No other associated features for there, isn't it, Devangana?
Yes, sir. Actually, we do not have the this thing, sir, photo, but the child, some of the facial features like dysmorphic features, prominent supraorbital ridges, flat faces, with sensory neural hearing loss, which has been described with this genotype, has not been matching with the child. The child did not have any of the facial features which has been described with these genes.
So then, Dr. Sarah, just from a question from radiology. How do we come to a likely pathogenic variant if the clinical and the imaging features are not matching?
Yeah, so it could also be, my question is again to Dr. Lokesh and neuro team. So could this be a HI picture on this syndrome itself? Can the hypotonia be sometimes possible?
Sometimes possible, because we have had children with Soto syndrome with extensive HI. Because of clear clinical phenotype, we could actually get the diagnosis. But when these things are not very clear, the phenotype is not clear and superimposed by something else, it's always difficult.
Okay. So in view of the likely pathogenic variant, it would be good to look at the variant details as to why they have labeled it as likely pathogenic. So if they have strong evidence wherein this particular variant has been reported in affected patients previously or present in the disease databases, then it would be significant that this could be a superimposed picture. So based upon hypertonia alone, I don't think we can rule it out. But so, obviously with the MRI findings.
Yeah, something like a double trouble? Is that?
In view of the variant, in view of the variant, yeah.
I'm somehow naive, but I think everything has to be interpreted in the clinical context. And the start of life of this baby, if I read the text in the first slide, is very difficult one. So this should not be pushed aside. This is for me a very strong argument for an acquired condition. And this is PVL in the broad sense. You have a lack of white matter, which results in microcephaly. You have the gliosis and a thin corpus callosum and normal infratentorial structures. This is, for me, absolutely compatible. Of course, you can always discuss about double trouble, but a genetic condition is lower on the list for me.
I don't think the imaging was done at the time of genetic test. Devangana or Dr. Lokesh? This is the most recent scan, I think, after the gene was. Would that have changed the interpretation?
Yes, a genetic test was done first, followed by the MRI. So.
Okay. So there was no imaging information, I think. Is that right? For the gene analysis, I think they primarily relied on the clinical picture of tone.
Genetic test. This one.
Okay. All right. So at least we are thinking more of an acquired insult on imaging and clinically than the genetic cause. But I think you will test the parents. Is that right? The next step.
Yeah, we'll test for segregation. Yeah.
Okay. Got it. All right. Thanks. Okay. Next case, Prituja.
Yes, sir. This is an 8-month-old child with paroxysmal event in the form of frequent startles that started since 6 months of age. She started having fever, and after the 3rd episode of fever, these fever-induced startles started, and parents even noted that there was deviation of right eye medially multiple times 1 week prior to presentation to us. As I mentioned, there was recurrent febrile illness, followed by which there was regression of the milestones as well. This child was born to third-degree consanguineous marriage with previous 3 miscarriages and had no postnatal complications. When the child presented to us, the head size was normal, could fix the gaze with minimal tracking, and child had started to sound with spasticity and brisk reflexes. Systemic examination were normal. Investigations were done outside, and that showed normal CSF with, sorry, I forgot to mention, normal lactate level. And EEG showed moderate encephalopathy with no epileptiform discharges. TMS was also done, which was normal. GCMS showed mild to moderate elevation of 2-hydroxybutyric acid, and then MRI had been done. So,
anything significant on the GCMS? Because I'm not aware of imaging findings of elevation of hydroxybutyric acid.
Nothing of significance as we know
Okay.
related to these conditions that I've mentioned.
Got it. The investigations done after the MRI or before? You covered the investigations.
It was actually this investigations were continued from the first one only.
Okay, got it. All right.
So the CSF, which was mentioned earlier, was normal. Lactate ammonia normal, TMS normal. So same investigations.
Got it. All right. And I think clinically, this was the differentials you're thinking about.
Yes.
Okay. I think the panel was done after the MRI, so we'll get back to that. I have only external films, and on top are the diffusion weighted sequences. No areas of restricted diffusion, at least in the visualized sequences, images over there. On the T2s, you can appreciate that there is a significant reduction in the supratentorial brain volume, predominantly in the peripheral regions. The cortical volume is significantly reduced. There are extensive confluent white matter abnormalities extending from the frontal lobes, the temporal lobes, the parietal occipital lobes. Also, the central white matter structures are demonstrating hyperintense changes. The basal ganglia are mildly hyperintense. In terms of volume, basal ganglia were relatively normal, but thalamus again demonstrated some areas of reduced volume there. Coming down posteriorly, brainstem again is demonstrating hyperintense signal changes, some patchy areas in the vermis. Cerebellar hemispheres appear normal, no volume loss over there. So predominant neurodegeneration going on in the supratentorial brain, extensive white matter abnormalities, some deep gray nuclei volume reduction, and some brainstem hyperintensities as seen on these sequences. Contrast was done, no significant meningeal enhancement over there, possibly some punctate areas. These are likely some areas, some perivascular or veins which are enhancing over there, nothing significant, no parenchymal focal lesions. So contrast doesn't demonstrate any significant enhancement. Spectroscopy, there was mild elevation of a choline peak, but I think the child was, what was the age, Pritija, at the time of scan, any idea?
This scan was done at 6.5 months of age.
Okay, so 6.5 months, again, the gradient is from the Na to choline, but it was slightly elevated. But again, no significant lactates or other peaks on the spectroscopy. On the imaging finding, given that the child had recurrent infections, primary immunodeficiency syndrome was the clinical diagnosed possibilities, and based on the imaging, one of the possibilities we thought was the interferonopathies, which can have these extensive white matter changes, neurodegeneration going on. We did not have a gradient sequence or a CT scan to check for any calcifications. But yeah, this could be one of the imaging differentials which we thought of. And then other neuroinflammatory conditions, such as HLH, can also have these extensive abnormalities, white matter abnormalities, and in the chronic stage can have a significant volume reduction. So I think primary immunodeficiency was the clinical and radiological possibility. And I think based on that, the PID panel was sent.
PID panel was sent, and that showed low levels of immunoglobulin G, A, and E, and lymphocyte subset was normal. Whole exome sequencing was done, and it showed mutation.
So these levels don't correspond to any of these possibilities, right?
No.
Okay, got it.
This condition is related with febrile illness-related regression. So the immunodeficiency panel, because the child had frequent episodes of fever, so infective etiology related. So genetic testing was done, whole exome sequencing with CME was done. That was suggestive of RNA SEH2B mutation. It was a homozygous autosomal recessive pathogenic variant, suggestive of Aicardi-Goutieres syndromes.
Okay, I'll open the case now if anyone wants to comment on their experience and similar findings.
Just a historic comment. The first cases of Aicardi-Goutieres syndrome were described about 30 years ago by Jean Aicardi, a giant pediatric neurologist from Paris, France, and Françoise Goutieres, a female. She was a co-worker of Aicardi. Both died in the meantime.
So, CSF, I think, wasn't done neopterin levels or interferon levels.
CSF, no, or just routine.
Any dermatological abnormalities?
Not noted.
Rash. Okay. Right. So the final diagnosis is an Aicardi-Goutieres pathogenic variant, and I think imaging and the clinical matches. All right. Thank you. And
thank you.
Now, thanks, Vidita. And now we'll move on to our next case. Ramya, are there?
Yeah. Shall I go on?
Yeah, please.
Yeah. So this is a 5-month-old female child who was absolutely normal. Second child of consanguineous couple, and this they went to some relatives' place, and then they came back home. The child was bathed, and the child was sleeping, and suddenly the mother noticed that the child went stiff. With all 4 limbs stiffening, and the child was not breathing, became blue in color. And then after that, the child had a huge bout of hematemesis by the time they reached the hospital. So little later, I mean, they have treated the child as seizures and given some oxygen. After that, the child little settled. Then the child had melena as well. From then on, that happened on Saturday afternoon, and from then on till Sunday afternoon, the child continuously had brief episodes of seizures, and that was going on, and with encephalopathy. And then we received the child on day 3 of illness. By the time we received the child was having an active seizure, and also the respiratory pattern was very poor. So we had to intubate the child, and then continue on ventilation. Slowly, the child had recovered, and we were able to wean off the ventilator, and there were no further seizures as well. So my main doubt is with the scan DDs. There were 2 MRIs done, one at the referral hospital, and then one with us on day 4.
Just a question before we move to the images. Ramya, this second seizure, how long?
This was again, the child got admitted after a week's time. Then the seizure was very brief, like 2 to 3 minutes.
Okay. All right.
Yeah.
Okay.
I'll come back to the other this thing after the MRI. Yeah.
Got it. First MRI, the images are not of great quality. At least the T2 sequences over here, there were no structural abnormalities, no edematous changes. And I don't have the diffusion sequence though, but I can confirm that there was no area of restricted diffusion on the diffusion.
Yeah, that was mentioned. Yeah.
Yeah. Okay. So at least on the initial scans with these limited images, cannot appreciate any abnormalities structurally or in terms of ictal edema. So we don't have diffusion, but yeah, as you have said that there was no abnormality on the diffusion. So the first scan was, I think we can call it as normal.
Yeah.
Then I think you did a CSF and TMS.
Yeah. Sorry?
Okay. Was this after the first scan?
Yeah. In our hospital, we have done this.
Okay.
Infective panel also was done in CSF. That is also not viral panel.
Okay. Then second scan done at the interval of how many days, Ramya?
3 days.
Okay.
2 to 3 days. Yeah.
Okay. Second scan, we have the diffusions, and you can appreciate that there are no changes of restricted diffusion, confluent abnormalities, cortex, subcortical regions, deep white matter, bilateral frontal lobes, parietal lobes, dominantly, again, you can appreciate these areas of restricted diffusion, white matter involvement, gray matter involvement, the parietal frontal lobes are extensively involved. Coming inferiorly, there are more selective cortical involvement along the anterior frontal, the parietal, the temporal, the parietal lobes on either sides over there, and some areas of the white matter demonstrate areas of restricted diffusion. Coming down more inferiorly, you can see that the posterior segment of the corpus callosum demonstrates diffusion. The occipital lobes, the posterior temporal lobes have areas of restricted diffusion, predominantly in the cortex and the subcortical white matter. Again, you can appreciate the changes in the occipital lobes. The brainstem and the cerebellar structures, in terms of diffusion, did not demonstrate any abnormalities. So it is slightly asymmetrical. In superficially, it is slightly symmetrical, but coming down inferiorly, it is slightly asymmetrical, as you can see over here and also over here. There were no abnormalities on the gradient sequences, no hemorrhage or calcification. Contrast, I'm not able to appreciate any significant enhancement. So I mean, again, also the CSF was normal. Predominant areas of cytotoxic edematous changes. Based on that, I wasn't aware of the duration of the seizures, but post-ictal state could be one of the differentials. They predominantly involve the peripheral regions of the brain, but I can also have involvement of the deep brain nuclei. The other possibilities were given that the first scan was normal, and we'll check with if it fits the LARD pattern.
Yeah, that was our first, I mean, main DD. So we got interleukin 6 levels also done. They were very elevated. 10 is the upper cutoff. The child's value was 110 in CSF. But then that is very non-specific. In hypoxia, also the interleukin 6 can get elevated. In LARD, those things. So PRESS was one of the differential given. So that is why we have done IL-6 mainly.
So PRESS, okay. So they have predominant peripheral involvement, but they have, I mean, being typical, they usually have vasogenic edema rather than extensive cytotoxic edema.
Yeah, that was not matching.
And if it was such an extensive involvement in PRESS, you would expect some areas of microhemorrhage too, but again, was not seen in our case.
Yeah.
So at least radiologically, I'm going with LARD, maybe post-ictal as the main differentials.
Okay.
So yeah, as I mentioned, it can have raised IL-6, but not specific. Any excitotoxic injury might present with these changes. So I think your question was, do we need to go with I think mitochondrial was the question, right?
Then because the second admission, the lactates were very high. So the admission lactate was somewhere around 110, and then the blood lactate was also elevated to the tune of 80. But the first admission lactates were all normal. I was not very convinced with mitochondrial clinically, but then the child had the little neuroaggression, which can be explained by this illness. So as a DD, can that be considered as one of my question? And second question, will it fit more to LARD or the post-ictal?
But both of them usually have seizures, so it can be changes can be LARD, but LARD, the phenomenon is because of the biphasic seizures, so it can be post-ictal. Both can be said.
Okay.
At least that is what I'm thinking, but I'll open the case now for any further.
Okay. Are there any clues to know that if it is LARD or it is post-ictal? Because the first scan was done well into the illness, meaning somewhere around 24 hours. So at least some diffusion changes would have been expected, is what I thought that time. Or some edema, at least.
Yeah. Typically 1 to 2 days, it can be normal. The diffusion changes usually come at around 3 to 9, that period.
Okay.
So there's a question, does high BP fit LARD and PRESS be still RD? I'm not sure of high BP and LARD. Ramya, do you have any?
No, generally high blood pressures are not reported in LARD. But this child did have high blood pressures after the scan, like 24 to 48 hours after the scan. And we attributed that to steroid.
For the kidney, okay, steroids, all right.
Kidneys were all good. Yeah.
Okay. Any EEG done?
Yeah, EEG is done, just showing a slowing, nothing significant pattern. No focal ictal spike wave discharges also. No interictal changes as well. Yeah, Melas was the second thing I thought after this lactate elevation. But
they're usually not, again, being typical, not extensive. They're usually more focal segmental kind of abnormality.
Even the frontal got involved, and then the first one being normal, the second being abnormal, that was also not a fit. So, so I think postictal and Aliadi are the close match. Melina and hematomes. No, that's what we thought. Then finally, we have gone with LFTs and liver workup as well. It seems to be probably a hypoxic event causing all that was is what our GI colleague had told. It could be that. Follow up with.
Even the splenium corpus callosum is typically seen in postictal changes and viral infections. So that also is a few. I think viral panel wasn't sent.
Yeah, it is sent.
CSF. Okay.
CSF viral panel is sent. It is negative, and the CSF is very normal.
Normal. Okay.
Yeah.
Okay, I think we're moving towards postictal ALRD.
Okay.
If there are any stroke-like presentations later on in future, maybe you can get a these. If they typically fit the Melas type picture.
Strokes. Okay, no, child doesn't have those things now. Vision is affected though, probably because of the posterior involvement.
Dr. Nayana is asking, how is the kid doing now? Any deficits?
Kid is better, but then child has some amount of pseudobulbar palsy and then vision abnormalities. Mild neuroregression is there. Probably child will pick up, but definitely neuroregression is there for now.
Are you considering a follow-up imaging?
Yes, sir. But this imaging is just like 2 weeks ago, so I'll be doing it little later. How the child, I'll see how the child improves.
The question is whether you will see some some bilateral occipital residual changes, which could explain also the vision problem.
Yeah. Probably I'll do a follow-up after some time, depending on the clinical
pattern. Yeah, that would be better. Okay.
Okay, thank you.
Right, thanks. The next case is a follow-up case. If Utkarsh is there, otherwise I can take it up. Okay, Raghu, can you make Utkarsh as a panelist? Okay, since it's a follow-up, I'll take it up. This was discussed in April. So this was a 3-year-old male with a history of delayed cry, developmental delay, and presented with a query of fever. MRI was done in 2021, which had similar imaging findings to the most recent scan. So the scan was discussed in April, and we came up to a conclusion of a possibly an ACTA2 mimic with these colpocephalic type appearance of the lateral ventricles, so the string-like or linear pattern of the intracranial arteries, and also there were some areas of abnormal gyration especially in the frontal lobes. The deep brain nuclei was slightly reduced, hypoplastic. The brainstem was squeezed due to compression on both sides laterally. There was a dysmorphic brainstem, better appreciate on the sagittal images. The corpus callosum was dysplastic, and there was areas of abnormal gyration, especially in the frontal and pedestrian regions. At that time, the possibilities or the literature which had similar cases were the genes of the MYH11. These were the only imaging findings which we could find which had similar imaging findings. And the gene was on both cases, the MYH11 was the positive gene. And then the child had underwent an whole exome sequencing, and these were the two genes of uncertain significance which came out, CHAMP1 and ATP183. a literature search on both the genes. The CHAMP1 gene, again, doesn't have similar imaging findings. The clinical picture, I'll probably leave it to Dr. Sarah if she's still there. And ATP1A3 also does not have similar imaging findings. Also, the clinical picture may not match. They have usually a gene of alternating hemiplegia, dystonias. Again, the clinical picture, the child did not have any facial dysmorphism. So I don't think the genes are a match, but if Dr. Sarah is there, she can probably take it over from there.
Yeah, hi, Dr. Nihaal. So these particular two genes that have been found, the CHAMP1 has been associated with significant dysmorphism and a very hypotonic face, high arch palate. So clinically, we can go back and look if the child has any of these features and to see if there is any dysmorphic correlation. And also most of them have significant speech delay. There are, I think, around 18 to 20 patients that have been reported previously. And all the MRI findings have been very varying and none of which match the findings that you have described. So although MRI is not a match, I think it would be good to go back and look if there is any dysmorphism that is matching and also do a parental segregation if it is a phenotypic match. And if not, I think we can just rule it out. And the other ATP1A3 gene associated with refractory seizures. So did the child have refractory seizures? Was there significant?
Just delay and febrile illness.
So that's what has been described, and dystonia as well as vision and hearing loss. So I think it would be good to go back and look. And if not present, we can rule that out as well. And the only significant MRI finding that I could find with that gene was polymicrogyria, which there was one, I think 3 children described with that condition.
Yeah, so I could find polymicrogyria and cerebellar hypoplasia with ATP1A3, but not such an extensive abnormality as seen in our case. So at least imaging wise, I think it doesn't match at all. But Utkarsh, if you're there and you're taking notes, that probably you can clinically check if the child has some dysmorphic features. All right. Thank you, Dr. Sarah. Next 2 sets of cases from Pune. Deepak, if you're there.
Yes, sir.
Go ahead.
He is a 7-year-old male child born first issue of a non-consanguineous marriage with global development delay since birth. Had chronic non-progressive ataxia, which is noticed by mother since 1.5 years of age. There is no history of seizures or abnormal body movements or neuroregression. There is significant family history, and it was in the next pedigree chart where there is all the males are affected in all the 3 generations. And father is also having intellectual disability and also ataxia. And father's MRI showed cerebellar atrophy. And on examination, he's having microcephaly. He's having a significant dysmorphism. There is flat foot. There is nystagmus. There is squint since birth. There is no telangiectasia. On CNS examination, his tone is hypotonic. Power is more than 3/5. And deep tendon reflexes are elicitable, and there are frank cerebellar signs like intentional tremors, fast pointing. All the cerebellar signs of dysradicokinesia, all are present, sir. And slightly more on the left side than the right, and there is intellectual disability. His father was examined, who is having spasticity in all the 4 limbs, but there are no frank cerebellar signs now in the father, and is having a left upper limb dystonic posturing and slightly reduced distal power. And this child was investigated outside before coming to us with all fundus and eye examination is normal, thyroid function tests were normal, and karyotyping, EEG, BERA, serum AFP, NCV, EMG, and all are normal. And MRI was done.
Okay, you put the child's picture, anything over there? I cannot appreciate. Okay.
Yeah, in the dysmorphism, I want to mention there is microcephaly, there is regress anterior hairline, but bushy eyebrows, broad nasal bridge, prominent ears, and clinodactyly. These are the significant dysmorphism signs, prominent ears.
Okay.
Is the MR from the father or from the child?
Sir?
The child,
is the MR from the father or from the index patient?
Index patients.
So you don't have an MR of the father?
No, we just have only paper reports, sir. They're not having the films.
Okay.
So we asked the father to bring it second time. He brought just the report that showed cerebellar atrophy.
Thank you.
Okay. So like the father, the child has the cerebellar atrophy. Supratentorally, you can appreciate that there is no significant findings, no malformations, no volume loss, no focal lesions, no white matter abnormalities, but posterior foci, the predominant changes are in the cerebellum. You can appreciate the increased interfolial spaces, cerebellar atrophy changes, the kernel sequences better demonstrate the contrast between the supratentorial brain and the infratentorial brain. You can appreciate again, there is parenchymal volume loss in the cerebellum on both sides. On the flare sequences, do not appreciate any hyperintensities of the cerebellar cortex, which can possibly narrow down the differential. So there was no flare or T2 hyperintense areas in the cerebellar cortex. Sphenium possibly at this stage is slightly hypoplastic, but the sphenium is slightly drooping there. But again, on the brainstem, cannot appreciate any volume loss. The pons is normal. Again, the brainstem ratios are normal. So primarily, the predominant findings are cerebellar atrophy. Diffusion, no diffusion changes, no SW abnormalities, especially in the basal ganglia. Spectroscopy is non-contributory, non-diagnostic. The spinal cord MRI is normal. No volume loss of the spinal cord and no focal lesions. These are papers from the Eugene, and at least radiologically, I could point out that cerebellar atrophy was the predominant finding, and a large list of differentials can be seen. The child had non-progressive ataxia. Again, this is a paper from Eugene, and possibly I'll let him take over and give us the possible differentials for what to consider for this child and the father. Eugene, over to you.
First, a comment or a question about semantics terminology. The question is whether you should call this cerebellar atrophy or hypoplasia, or just descriptive to say the cerebellum has somehow a small volume and fissures are enlarged. If it's just one examination, you cannot be sure is it ongoing or is it static. If it's static, some people call it hypoplasia just to distinguish it from an ongoing condition. This could well be a genetic condition, even in a sporadic case, and here perhaps even more if you have probably a similarly affected father. There are now a large number or a considerable number of genes, dominant, recessive, X-linked, responsible for so-called non-progressive congenital ataxias, and this would be probably the next step to do. I can add that, of course, this is not an entity in terms of genetics and clinical situation, but overall, children with congenital ataxia have a higher prevalence of intellectual disability, of microcephaly, of autistic features, and of seizures. Also short stature, if I forgot to mention.
That's it, Eugene. Thanks. Dr. Sala, anything to add? Genetically, clinically? I think we have, imaging-wise, I think we have covered. Okay, I think Dr. Sara's left. So, Deepak, genetic disorder, whole exam would possibly give you the diagnosis.
Yes, sir. We are planning ahead. Yes.
And these are differentials, at least limited differentials, which you can find imaging-wise and also clinically, you can possibly correlate.
Okay, thank you.
Yeah. Next case.
Yes, this is a day of life 12 baby, born full term, IUGR 2.25 kg, cried immediately after the birth, had NICU stay on day of life 3 for phototherapy in view of jaundice, and then discharged. On day of life 5, had one episode of left-sided focal clonic type of seizure for few seconds, after which a baby was loaded on phenobarbital. She had another episode on day of life 7, and then was loaded on Levira. No further seizures. Currently, baby is day of life 12. And there is a history of elder sibling who is currently 5 years of age, having preterm birth with MRI report showing periventricular leukomalacia. They didn't have the fillings and had one episode of seizure at 4 years of age. This baby head circumference is 33 centimeters. There is mild hypotonia, and rest of the examination is normal. Metabolic profile, blood sugars, everything, urine ketones, all are normal, sir. And EEG showed immature background for age, frequent multifocal theta delta complexes mixed with few spike flows. CSF biofile was sent. The MRI was also done, sir. We will discuss MRI.
Okay. Okay, MRI on day, which day?
Sir, MRI, sir. Day of life 8, sir.
8, okay. So extensive white matter areas of restricted diffusion, confirmed abnormalities, especially in the frontal lobes, the parietal lobes, but predominant periventricular areas extending up to subcortical white matter. Almost some areas demonstrate this radiating fan type pattern. Coming posteriorly, you can see the central white matter is involved, the ventral subthalamic nuclei over there, the periventricular regions, again, predominant changes in the periventricular regions, but extending up to the almost the subcortical area. On the ADCs, corresponding low single changes. Again, some areas you can appreciate over here are like a linear radiating type pattern. No hemorrhage on the SWI or GRE sequences. T2 has some areas of edematous changes which correspond to the diffusion abnormality, but no structural abnormality on the T2 weighted sequences. And sagittal sequence, brainstem and cerebellum did not demonstrate any significant abnormality. Posterior fossa again on the axial sequences, no significant changes in the cerebellum. So based on that imaging pattern on the diffusion weighted sequences, radiologically, I thought the primary differential would be a non-congenital neonatal viral infection, which has this typical white matter extensive involvement. It can go up to the central regions of the white matter. Polygonal nuclei can also be involved. But these are the differentials of this imaging pattern. The clinical presentation would possibly dictate the final diagnosis. But yeah, this imaging pattern can be seen in all these viruses. Paricovirus is the most common. So yeah, thinking of an acquired cause. Deepak, yes, any other questions you wanted to ask?
Only thing is, other than infective, can this suggest, because other sibling has PVL changes, so anything metabolic DDs could be possible or not? That's the only query. If not, we have sent biofile.
Okay, but that sibling had PVL.
Yes, sir. Yes. So no relation to that, no, sir.
I possibly would need to look at the images, but if they mention it as PVL, then it would be PVL. That PVL will be secondary to an acquired cause. Yeah.
Okay. Okay. Sure.
There's a question from Arka. Arka has asked molybdenum cofactor. At least imaging-wise, they predominantly involve there's also involvement of the anterior basal ganglia, and there's a predilection probably towards the peripheral regions of the brain rather than the periventricular regions. The cortex can also be involved. The subcortical white matter is predominantly involved, and there is usually some basal ganglia involvement. So molybdenum cofactor, at least on the imaging pattern, I wouldn't put it in the high differentials. I think the other question you had was the seizure episodes on day 7 of life. Is that common for a neonatal infection? Is that right, Deepak?
Yes, yes, sir. Like day of life 5, 6 it occurs. Yes, no, okay. no issues. Yes. Please send the biofile. Once we get the report, I'll get back.
Okay. All right, I think we are moving towards neonatal viral infection as the primary differential.
Yes, sir. Thank you, sir.
All right, thanks. And our last case, Dr. Joy, over to you.
Yes, good evening, everyone. So this girl is currently 2 years, 10 months, and she did not have any significant perinatal insult, although she had a delayed cry, but the history of encephalopathy is not upfront. And then she had a global developmental delay with some gain of milestones. And so she came to us for the first time in May. And just before that, she has had a febrile illness for which she was admitted, which was treated as meningitis with CSF cells of 120, protein was slightly raised, sugars were normal. So she came to us with a history of regression of milestones after this febrile illness. And on a detailed history, the parents also revealed that she used to have frequent febrile illnesses even during the first 2 years of life. And she used to regress milestones wise during those episodes, only to gain them again. So we have two MRIs, two interval scans, one at 1 year of age and the other a recent one. And on examination, she had dystonias. And her first cousin is also similarly affected.
Okay. So the initial MRI, again, similar to one of our cases discussed earlier, extensive white matter abnormalities, confluent abnormalities in the bilateral cerebral hemisphere. Here, also the basal ganglia and the central white matter also demonstrate hyperintense changes. There is volume loss in the supratemporal brain, predominantly in the cortical region and predominantly in the frontal lobes. Coming down posteriorly, at least at this point of time on the T280 sequences, the temporal lobes also demonstrate these hyperintense changes. And on the flare sequences, these hyperintense changes, some areas, especially in the subcortical regions, have a rarefied appearance. Also, the anterior temporal poles, you can appreciate some degrees of white matter rarefaction. No structural abnormalities per se, and I cannot appreciate any focal lesions. So predominantly white matter abnormalities, also involvement of the deep brain nuclei, neurodegeneration related changes, ventriculomegaly secondary, likely secondary to some degree of volume loss. There's a persistent cavum septum, a normal variant again, and white matter refractory changes in the frontal lobes and also in the anterior temporal lobes. You can appreciate the white matter refraction better on the T1 flares. And again, you can see that you have these extensive white matter areas and some areas of cystic degeneration or refraction in the anterior temporal poles. Similarly, on the coronal sequences, again, extensive white matter abnormality, the posterior fossa structures are relatively spared. And then this is the follow-up scan a year later. You can see that there is progressive volume loss. Now also there's slightly asymmetrical as compared to the initial scan. The right hemisphere is more predominantly affected, especially the temporal lobes. You can appreciate cystic encephalomalacia, gliosis over there. Again, extensive volume loss in the bilateral cerebral hemispheres. Coming down to the flare sequences, refractory changes again appreciated. Now the basal ganglia also demonstrate the hypointense abnormalities. The T2, on the T2s, you can appreciate that the basal ganglia, especially on the left side, is slightly hypointense. That will possibly correlate that with a T1 weighted sequence. Again, refractory changes in the temporal poles. Diffusion weighted sequences, there are areas of restricted diffusion, predominantly in the cortical regions. You can appreciate some areas over here, the frontal cortex, the parietal cortex over there, and some areas in deep brain nuclei, as you can see over here, and also in the ventral brainstem. The non-contrast T1 demonstrated areas of increased T1 shortening in the bilateral basal ganglia. We don't have an SWS sequence or a CT scan, but these are possibly related to increased or abnormal mineralization. The corpus callosum is thinned out, and also the brainstem is reduced in volume. If we take the white matter refractory structure, abnormalities, these are the differentials, and the possible likely differential, the primary differential I would consider was an Aicardi Guthrie syndrome. I think there were no calcifications in the periventricular regions, but per se, I don't think we have a CMV history or microcephaly. The other differentials are as listed over here. And then if you consider the deep brain nuclei to have these hyperintense changes to be calcifications, this paper outlines white matter abnormalities with calcifications can be seen in Aicardi Guthrie, cocaine syndromes, and also congenital CMV, RNase, T2 leukoencephalopathy. Similar imaging findings as seen in our case, extensive white matter changes, temporal lobe abnormalities, refractory changes, and basal ganglia calcifications can also be seen. Calcifications in inherited disorders, these are differentials again. Cocaine syndrome has more rock-like calcifications with cerebral atrophy also added to it. Krabbe's has thalamic nuclei, thalamic abnormalities. Mela's Krenzer syndrome have basic ganglia abnormalities, but the extensive white matter involvement is different to what we have seen in our index case. Aicardi-Goutieres or interferonopathies can have these specific classifications. I think a question was asked of Kearns-Sayre syndrome. The white matter changes are slightly different. They are more peripheral to central involvement. The subcortical white matter is more commonly involved. It is more confluent, more symmetrical. I don't think the child had any ophthalmological abnormalities, so I wouldn't consider Kearns-Sayre a possibility. Thinking of Aicardi-Goutieres as or interferonopathies as likely possibility, Dr. Jui, I don't think HLH will also fit to any chronic neuroinflammatory conditions. No organomegaly, I guess.
So no, yeah. So no organomegaly, and the hematological profile is also not like HLH. So these T1 hyperintense basal ganglia, you are taking as calcifications probably.
Yeah.
Okay. Okay. So any possibility of these since the child had an acute febrile illness, it being some sort of a hemorrhagic necrosis?
Necrosis also can have T1 hyperintense changes. T2s usually don't have the hypointensities, but I would need SWR CT to be confident for a calcification.
Right. All right. So I think I'll plan sending the genetics for this child.
And no features of torch infection, right?
So the birth weight was 2.1 kg, which is on the lower side. There is no history of fever with rash in the mother during the antenatal period. But usually torch infections present sort of like a static insult sequelae. The children are delayed, but they gain milestones with time. They do not have history of recurrent episodes of regression, like in this case.
Eugene, you have any comments for the case? Any other possibilities?
No.
Okay. All right, Dr. Jui, I think maybe work on the lines of interferonopathies and possibly have a feedback.
Right. All right. Thank you.
Right. Thank you. And that's our last case. So we'll again meet in 2 weeks' time. You can email me if you have any cases or you want to present any cases. I think last date is 21st June. So yeah, we'll see you in 2 weeks' time. Thank you everyone for your cases and your discussion.